This is part 3 of trauma VIVA of lower limb for FRCS exam and postgraduate orthopedic exams. This is concise orthopedic notes book I used during revision for FRCS exam. And this is Orthopedic Academy YouTube channel. Also, I followed for 2 years or more for preparation of the exam. I'd like to disclose that some picture and comment are based on Orthopedic Trauma Association lectures available on their website. Our first case today, this is plain X-ray or plain radiograph of part of the femur. First of all, you should ask for full length X-ray for all slides, for all fractures. Don't accept part of the femur or single view. Okay, he will tell you this is what is available, but because you can get surprised when he give you another view with, for example, hip dislocation. The treatment will be different, and also it will be bad for you because you will tell something and you will withdraw after that. So you will ask about full length X-ray from hip to knee. Also, you should see this total knee prosthesis fully. So you will ask for X-ray of full tibia also. You will ask for history about mode of trauma, presence of pain before this injury. It is a pathological or not, it is open or not, it's type of trauma. It is isolated trauma or polytraumatized patient. This will make a difference. Also, this total knee, the patient has complained about it before the injury or not, has pain or not, like this. You can ask for previous radiograph for the hip prosthesis and the knee prosthesis as well to see any signs of loosening or instability, because it will be considered for all treatment types. So he will tell you, okay, the knee prosthesis is stable, there is no signs of loosening, and the hip prosthesis as well, also no problem for it. How you will fix the fracture? I will fix the fracture with a long plate. The principles here for fixation of fracture like this, for fracture distal femur with prosthesis in the proximal femur, the fixation construct should overlap the proximal prosthesis, either nail or stem, because this one is okay, this is a stem, but in another slide or another case, it could be proximal femoral nail. So the two prostheses should be overlapped. If it is a nail, it's a short nail, it can be converted to long nail if the proximal fracture is not healed. Okay, but if a prosthesis stem like this, okay, the blade should overlap the stem. The fracture also the same principles we discussed in previous talk. No need to fill all the holes. This long oblique fracture, it can be stabilized by circulage. Don't put any screws in the fracture site. Of course, we will use locked blade. This is a more clear X-ray. So the prosthesis is hemiarthroplasty, as you see, and the overlap is like this, and not filling all the holes. This is ideal, not filling all the holes and not putting screws at fracture site. This is another example. There is no knee prosthesis, but there is hip prosthesis. This is a common case scenario also in the exam. Describe the X-ray. Okay, this is a plain radiograph of total hip arthroplasty, complicated by periprosthetic femoral fracture. How you classify this fracture? We will proceed to Vancouver classification. So this one will be either B1 or B2 or B3. B1 if the stem is stable, no signs of loosening. Here you can see signs of loosening. Or B2 if you see signs of loosening. B3 if there is fracture around the stem, there is signs of loosening and inadequate bone stock. So this one, there is adequate bone stock, but there is loosening signs. He will ask about where are the loosening signs. The fracture itself is around the stem, and there is widening between the cortex and the stem. Also, malpositioning of the stem is a sign of loosening. Subsidence is a sign of loosening. So, what is the treatment? Is a revision of the stem. He did revision for both because also I think the stapulum is also there is the cup. There is sign of loosening as well. Loosening is confirmed intraoperatively, and it can be revised by long stem total hip, and to fix the fracture with circulage or cables around the stem. What is your workup before proceeding with this treatment? First, I will ask about history of trauma. What type of trauma, mode of trauma, any history of pain before this fracture. You will ask about any signs of infection, symptoms of infection, fever or delayed wound healing. Review the previous radiograph for looking for progressive signs of loosening. All of these should be considered. Also review the operative notes of the previous surgery as well. This is another type of periprosthetic fracture. According to Vancouver, this stem is stable. There is no signs of loosening, but the fracture around the stem, so it could be B1. The workup the same, like we said before. So we will keep the stem, but we will fix the fracture with a long plate with cables around the fracture. We will splint hold the femur by long plate. So it is Vancouver B1. Vancouver B1, don't forget basic osteosynthesis principle. Choose absolute or relative stability and create it. So we prefer relative stability, but with splintage hold the femur. Don't disturb biology. So we are using a biological plate. But test stem intraoperatively also, because it looks not loose, but intraoperative, there is maybe loosening when you examine the stem itself. This is another periprosthetic fracture, but the fracture is here is below the stem. So it is Vancouver type C. And he may ask, what is the cause of this fracture? This fracture may be caused by stress riser effect because there is one fault here that the blade stopped directly under the nail. So the area between the blade end, proximal end, and the stem uh, had stress riser effect. What is meant by stress riser? Concentration of stress directly proximal to the blade. So concentration of stress here caused breakage of the bone. Here, the fracture at the end of the blade. This blade was used to fix this fracture, which is not fully healed. Should comment on that. So what is the treatment? The treatment is to revise this fixation and fixing both fractures. We will use a very long blade, splinting the femur from metaphysis to metaphysis and overlapping the blade, the stem by either unicortical screws or oblique screws, or we can use here cable blade system. He used a small blade also to fix one fracture here. Maybe because this fracture, he couldn't get longer blade than this one. This is another type of fracture. You can count it as Vancouver C also. So uh, sorry, this is another X-ray of proximal femoral nail with fracture distal femur. How you will fix it? The same principles. When you should avoid stress riser. So we will fix this fracture with a very long blade overlapping with this proximal femoral nail. Lock this blade from one metaphysis to the other. If the patient, if the type of fracture allow usage of long femoral nail, okay, it will be much better than using two construct. But because this type of fracture is very distal, so it is not suitable to use intramedullary nail. For Vancouver C, fix the fracture, don't create new problem. Overlap the implant, no stress riser is allowed, blade holds the femur. These are the principles. This is a plain X-ray of intertrochanteric or subtrochanteric femur fracture. This subtrochanteric femur uh, fracture fixed by proximal femoral nail, but 6 weeks after that, during follow-up, discovered to have this fracture. It is incomplete fracture, but it will be complete after days or weeks. So how you will deal with this one? We will ask ourselves, the proximal fracture is healed or not? If it is healed, maybe if the patient presented, for example, after 1 year or 18 months, okay, we will deal with this fracture alone. But if the fracture is not healed, we should use a implant suitable for both fracture. The priority is the optimal treatment for new fracture, especially when prior fracture is healed. If prior fracture is not healed, we adjust accordingly. Two fracture, two treatment. So we admitted the patient and revised the proximal short nail with intramedullary long nail, which will fix both the fracture. I think the fracture is healed here or partial healing. So we used a long nail. Here, this is the fracture. This is another case also common. This patient is 55 years old, left side pain, no history of trauma. What do you want to ask the patient? I will ask the patient about when the pain started. You should ask about medical history. Medical history uh, of using bisphosphonate because there is lateral peaking over lateral cortex. Here there is peaking, so it is about to break. This is maybe sign of stress fracture as well, maybe bisphosphonate fracture. We should ask about history of uh, other diseases like cancer, like uh, renal failure, renal impairment, like this. We will ask about surgical history. We will ask about history of fever or pain in other area. We will ask about the right side, the other side is painful or not. We will take radiograph, this one AB lateral. We will take radiograph of right side as well, because you can find another the same problem in the other side. But how you will manage? Uh, there is peaking of lateral cortex and its subtrochanteric area. This is a pathological fracture. The patient has left side pain for a few weeks. This patient will be treated by prophylactic nailing. This is a typical femur fracture, low energy femoral shaft fracture with characteristic appearance, which is peaking of lateral cortex in subtrochanteric area or in the shaft. It is caused by combination of unfavorable femoral anatomy, varus, anterior bow, impaired bone healing and remodeling, like treatment of bisphosphonate. Frequently, but not always associated with bisphosphonate use. Successful treatment, combination of medical and surgical management. High rates of delayed union and non-union compared to standard femoral shaft fracture, so should be considered in the consent. Disease process often manifest bilateral, so you should take radiograph of the other side. This is another case of periprosthetic fracture of total knee arthroplasty. Also, the patient has total hip arthroplasty in the same femur. So the same principle is to overlap the implant and to fix the fracture with low stiffness implant, not filling all the holes. The same principles. Same principle. Frequently asked in the exam, so I repeated in many slides. This patient, geriatric patient, osteoporotic, has total hip and total knee, supracondylar periprosthetic distal femur fracture, treated with ORF. He had trauma, he had fall, and I don't know if this is the previous fracture or not. The question may be, what is the cause of this failure? New fracture distal to total hip stem at proximal screw site. Maybe it is stress riser effect. No screw fixation to overlap the fixation of the blade and the stem causing stress riser. Yes, the cause is stress riser. He used the long blade, but he didn't overlap the fixation. The fixation should overlap the stem. The blade with fixation should, this is not broken blade, no. It is broken at the distal fixation end. The proximal fixation end, sorry, should be overlapping the stem. So the revision here, as you see, long blade is blending holes the femur and overlapping whole system from metaphysis to metaphysis. Now it is healed with good callus. Patient is ambulating. Thank you.